All right. Well, welcome everyone. I'm so delighted to see you here. As you know, today I am very excited to share with you some of my ideas about menopause. I actually think that menopause is a very interesting thing. We are evolutionarily geared to die. We're conserved to die, but we're basically made to reproduce in order for the species to survive. So everything about our evolutionary expression has to do from the Big Bang to our DNA, to how we express ourselves. We exist in the energy of the universe. And then through us comes a genetic code and a timing of when we begin to do things and when we end things. So it turns out that for us women, there was no evolutionary pressure after we made babies to continue to exist for a longer period of time. And there is a certain timing where our eggs are able to produce, our eggs are in the ovary, we're able to ovulate, and we're able to produce estrogen. After we lose that capacity, we are without estrogen. And what's very interesting about that signaling is that it's a messaging to the rest of the body that we are beginning our demise. We're beginning to go. And as we will discuss in different ways, we actually, at the loss of estrogen, we begin to disconnect from very important channels within our brain, and our metabolism changes so that it begins to age to some extent, and we get more progressively inflamed. Things begin to change for us. We begin to decompose in a very mild way that it evolves to more ultimately our going. One of my big interests is to figure out how it is that we can change this epigenetically. If we are geared genetically to age, can we change the way that we mature over time so that we don't have this unfortunate legacy that was given to us by evolution? And in fact, it is possible to change the way that we age. And I am here to stand for all of us women. We women live 30 to 40 years after the menopause. And we can choose to be vibrant and to have the best of our lives and to give the wisest parts of ourselves, of who we are, what we have learned as mothers, as generators of life, as givers of energy to the whole world. At this time, it's time to use our wisdom. It's time to use our skills to bring it forth to others and to create wellness in the world. And all here have unique talents and gifts that we have developed as a result of our growing, our learning, and our experience. And I truly believe that if we do this right, the menopause is a time to launch ourselves to a new level of being. So I feel so strongly about it. And many of you know me. Many of you happen to be my patients, and you know how strongly I believe that we can change ourselves and we can heal ourselves through connecting to and aligning our minds, our bodies, and through that connection, aligning to the higher consciousness that we have, which is the higher intelligence. It is the awareness that we can share with others. So my intention tonight is to talk to you about the menopausal transition as a new entry, but I want to give you awareness. I want to give you information. And I'm also coming from this as someone who has been trained in feminine-powered leadership. So I want to share with you that I'm giving this talk not in the usual way that I give a doctor's talk, but I'm giving it more in a way that we work collaboratively together, that we grow together because we have immense intelligence amongst us. And one of the interesting things that happens during the menopause is that everybody experiences alone. There's 50 million women in the United States that are having menopause, are experiencing menopause. Half of the people in the world are women, okay? 80% of us have significant menopausal symptoms after we enter the menopause, and yet we experience this very much alone. And I would like to enter this discussion with information. I want it to be playful and silly, and I want to tell you that in the generative feminine way that I'm trained, we're all here and we're all good. We all have a lot to share. There are no silly questions. There's no stupid questions. If somebody has a question, that means that a lot of other people have the same question. So I want to create a container of safety for all of us. And I'm coming from a place of love, non-judgment, and I want us each to be empowered and to know that no one is perfect. We're all perfectly imperfect, but we're all brilliant at the same time. So if we can allow that to happen for all of us, then and if we can all agree, give me a wave that you're all going to be with this loving feeling, generative feeling and sharing and the entire wholesomeness to the group, then give me a wave. And then we have made our commitments. Do I have everybody? Good. Well, thank you very much. So I feel that at this point we have made our commitments. And now, as I always do, I'm going to take just 1 to 2 minutes to ground us. So I'd like us all, I do this with all of my medical students. I believe that if we do a 1 minute or 2 minute grounding time, we're all going to have more curiosity and clarity in our minds. We're all going to be able to be to take in a lot more information, and we will have no distractions from other silly thoughts that keep coming up to our minds. We're going to be present now. So I'm going to ask you, please, to close your eyes and begin to take some nice, deep belly breaths. Nice belly breaths. And bring yourself from wherever you've been today to this space where we're surrounded by such beautiful women, and Eric, who's my dear husband and IT guy. And let's just center ourselves where we're sitting. By feeling where we're sitting, we ground ourselves, feeling our hips, feeling our body settle into itself after our mind has been everywhere today. We're here together and connecting to the earth, our mother, and extending to this beautiful world that we live in, connecting to that place. And then bringing that energy to our hearts, to our minds, to our essence. And from that empowered space, extending it to others in this beautiful circle of women that seek to learn, seek to grow, and seek to be empowered. Sending empowering energies to them, and receiving the empowering energies that they send to you. And with this wonderful connection between us, come back to this space. Take a deep breath, and let's begin. Okay, so I would like to begin by telling you the story of my menopause. I want you to know that even though I'm an endocrinologist and presumably I know so much about hormones, I was blown away first when I was pregnant and gave birth. I had no clue that hormones could be so powerful. And then when my menopause came, I ended up, perimenopause, because this is a long story and things begin to change. I ended up in the emergency room twice. The first time I showed up, I was having palpitations and I was feeling that I was having a heart attack. I was having heartache. And it was because I was feeling at that point rejected by my young teenage daughter that was beginning to become her own. And I was taking it very personally. And I truly had heartache and ended in the emergency room. So then they sent me out. And then a few months later, I was hospitalized because I developed double vision. Well, it turned out that as I was losing my hormones and my estrogen, my body became more inflammatory. And I have underlying autoimmune disease. So I ended up being admitted and I was having brain inflammation. It turned out that my ANA was very elevated. And it's not clear whether I had a mini stroke or whether I had an atypical migraine, but I was definitely not well. So because of these issues, I went to a neurologist. And the neurologist did extensive testing on me and found nothing wrong. And he considered the possibility that I was depressed and menopausal. And he, of all people, recommended hormone replacement therapy and an antidepressant. And that was very amazing to me because being the way that I was, I might have known better. But I didn't know. We don't know, even the most learned people don't know what's going on with them. And that's why we have to have a conversation. So it's important for me to just be humble with you and tell you that we're all the same. Even though I have this doctor's degrees and all of this knowledge, we're going through this. And when we're going through this, it's so foreign to us that we don't identify it as the fact that, in fact, we're going through a process. So I often deal with this. As you know, I'm an endocrinologist, so I can identify it in other people, but not in myself. And I've taken care of thousands of patients, and I've been able to help many women sort out the process of the perimenopause and the menopause and the postmenopause. And it turns out that it's really a very tough issue for us because for the last 2 decades, women have not been treated correctly for their menopausal symptoms because of faulty studies that popped up a while back that we will talk about. But there have been 2 decades of women that have not received the correct treatment for menopause. And also doctors stopped knowing how to treat women with hormones for the menopause. I have always felt so strongly about this that I have been giving hormones to everyone that can for the longest period of time. And I'm very experienced with managing the potential risks and some of these things I'm going to discuss today. So are there any comments at this point from anyone, or anything before I move on to a little bit of an informational part of this discussion? We good? Any hand raisers? Okay, looks good. So let me just for a moment share screen, and I'm going to go back and forth because I want this to be interactive. So let me just share the screen for a moment and get to my slides here. And can everybody see this? Okay. So I want to first describe how it is that this happens. So this is women from the age from where they are born until their 60s. And it turns out that, you know, it's the eggs. This is why we're here, to reproduce. Is these eggs that actually are ovulated by our ovary, and that's what produces the estrogen. And what you can see is that even at the beginning, even before we're born, we have 10 million eggs. By the time we're born, it drops to 1 million, believe it or not. And then there's a progressive decline at the number as we age. They say here that the optimal fertility time is 18 to 31, even though many women are now delaying having children later on. And back here, the chance of fertility is about 5%. But as you can see, there is a progressive decline of the eggs. And with that, as the egg supply declines, we have no more estrogen. And that's where we enter the menopause. But during this period of time, we have this decline of estrogen, and this is what we call the peri-menopause. So I want to then move on to the common questions that people ask. Am I in menopause? If I'm not in menopause, can I get pregnant? Or if I am in menopause, can I get pregnant? Is it common for me to not have to want sex with my dear partner? How did I lose my interest? Why am I gaining weight? Is it the thyroid? I'm feeling so exhausted. I feel so hot, and I have these drenching sweats, and I'm in the middle of a major meeting. This is a CEO of a company, and she's dripping with sweat and having to leave and dry and going back and forth. And it's a lot of symptoms happen around this time. So I wanted to discuss, to begin with, that there are various stages to this transition. There is what we call premature menopause, and that's when we lose our hormones before the age of 40. And this can happen for two reasons. The most common one is called premature ovarian failure, and it's because we have an autoimmune disease that attacks the follicles in the ovary. So the eggs die faster and cannot be fertilized. That's called premature ovarian failure, and it's a really tough thing for a young woman who in her 30s who's wanting to have children to be told that they can't do it. So for women with autoimmune disease that have it early on, we have them save their eggs early on so that they can use them later on. The other possibility for premature menopause is if someone loses their ovaries and their tubes for some reason, or have a total hysterectomy early on. And this is commonly done with women that have the BRCA1 and BRCA2 genes. It is recommended that they have an early removal of their ovaries because that decreases the risk significantly of them having ovarian and breast cancer. So this happens this way. The problem is that when you're a young woman and you have no hormones, it's really tough, especially if you're 30 or 40 and you're expected to live another 70 years. You've begun your aging process. faster. And then we have the perimenopause, the menopause, and postmenopause. I'm going to stop the share so I can talk to you about these individually. So in the perimenopause, we have a beginning of the lowering of the estrogen. And one of the interesting and important symptoms of the perimenopause, in contrast to as we enter the menopause, is that there's a lot of mood issues going on. So we have more anxiety, more depressive symptoms, and we can have a lot of irritability and difficulties. And so that the beginning of perimenopause is usually felt in the head as psychological symptoms. So, and in the perimenopause, it's very interesting. Some months we have a huge amount of estrogen because a lot of follicles are ovulating, a lot of follicles are producing estrogen, but they're not being ovulated. So there's no progesterone. So you may not have a period if you do not ovulate, but you have these large numbers of follicles that are producing estrogen. So you may have breast tenderness, you may have a whole bunch of symptoms, or you may have nothing. And then on some months, you have super low estrogen. And in that month, you have hot flushes and night sweats and other symptoms, and it goes back and forth and back and forth. And so between the moods and the swings back and forth of the hormones is rather difficult. So for some women, we try hormone replacement, we try birth control pills because they're young, and this can stabilize the system for a while. There's also migraines that happen at this time, which can be stabilized with some birth control pills. So when we go into the menopause, what happens is that there is no estrogen, although sometimes there may be a peak every now and then. So in the United States, it is defined that you have to wait 12 months without a period to actually call it formally menopause. But technically, if you've lost your estrogen and your progesterone and the hormones that help you, you are going to be in menopause, although you may have cycles of something changing, but you're in that process. And I'm asked about what is the possibility that I might get pregnant if I'm 50 years old, and it's actually quite slim, but there is a slim chance that you might get pregnant if it happens to be one of these months. So it's recommended that some kind of birth control protection, whether it's condoms or whatever it is that you're using, that it be used until finally your body is convinced that you're having no hormones. And then there is the postmenopausal period, which is then the duration of time that we have no hormones over time. And then we get used to it, or we continue to have symptoms. So 80% of us are going to have symptoms of menopause, and some of us will continue to have them for 10 years or longer. So this is a process that is very individualized. Okay, so any questions about that from the group? Take a look at the group and see how everybody's doing here. Are we good with that? Okay. So now let me go to a little bit more education, and I'm going to share my screen again. And I want to talk to you about some of the symptoms of menopause. And then I'm going to open it up for the group to hear a little bit of what people are feeling. But in essence, I like to divide this situation into a few domains, okay? There is the vasomotor symptoms, and those are the ones, of course, the night flushes, the night sweats and the hot flushes. And we actually really understand why this is happening. So it turns out that there are these very interesting neurons or nerve cells in the brain that are called the candy neurons. And normally their secretions, that is the peptide that they secrete is neurokinin, and that's normally suppressed by estrogen. If estrogen around, these little neurons don't secrete the stuff. But if estrogen is gone, these little guys grow and they get bigger and bigger and bigger, and they stretch out, and then they begin to secrete something neurokinin 3. It turns out that this peptide regulates thermal regulation, or your temperature, and it's linked. So that every time, so in essence, whenever they release their peptides, the body recognizes that it's hot, and your blood vessels dilate, and then you release, you get hot, then you dilate, you have a sweat, and then you cool off. So we actually have a mechanism of why it is that this is happening, which is incredibly important, because there's women that can't take hormones, and soon we're going to have the capacity to help them with this. There's many other treatments that we'll discuss, but I just want to tell you the biology of this, which is very exciting and has just been discovered in the last three to 5 years. So it's very exciting. So then I would say there's the psychological symptoms, which of course have to do with being depressed or anxious. But some of my patients just are highly bitchy, you know, and they have a really difficult time with people. They're irritated by everyone. And I will tell you, I don't know whether she's in this group or not, but I have one of my patients who happens to have one of these cancer breast syndromes. And she said to me, I'm going to kill someone if you don't give me hormones. So we ended up treating her. But I just want you to know that you know, there's pilots that are women pilots that are driving airplanes, and they just don't feel well to do the job, you know. So this is a significant issue in terms of the psychological realm. Then there's a whole bunch of physical stuff when we lose our estrogen. I would begin to say that the bones are deeply affected because we begin to break down bone faster. Our brain is affected because we are not connecting as efficiently to our surrounding synapses. We're not synapting as well to other things. So we may have some issues with word finding or cognitive decline in that regard. Our vagina gets affected, and so does the urethra, the opening where the urine comes out, and we begin to get urinary infections or urinary frequency. There's also the issue that we begin to lose weight, to gain weight. And that's because there's a whole bunch of metabolic things that happen to us as we lose our estrogen. Our resting metabolism slows down, but also we're not sleeping. So when we're not sleeping, we actually slow ourselves down, and we're hungrier the next day because we secrete a hunger hormone that comes from the stomach. So between the combination that we're losing our estrogen, we're not sleeping well, many of us are actually changing careers to higher levels. We're up leveling ourselves, or so we may actually have stresses from our job that add to the situation. So there's a whole bunch of factors here to contribute to the weight gain. And also there are some issues that happen with our gut. There's a gut-liver connection and a gut-brain connection. And when we lose our estrogens, the bacteria of the intestines change. So as a result of that, we actually, the liver begins to become more resistant to the actions of insulin and begins to store fats in the wrong places. And you will have noticed that the typical menopausal woman loses her waist a little bit and becomes more rounded in the belly. And that's a combination of all of these metabolic factors that are happening here. Of course, the heart is very affected. The cholesterol changes. We begin to put some fat around the heart. Our carotid arteries become a little bit harder. So there's something highly protective about the fact that hormones are around. And I'm going to move then to, I'm going to stop and share for a second. I'm going to move to the sexual aspects of this. And it's really true that when estrogen goes, we get dry. So the vagina becomes drier. The inner lining of the vagina without the estrogen loses its acidity. So it becomes more alkaline. So we're more likely to have not just urine, and the urethra also depends on the estrogen. So that's how we get more urinary infections, tract infections. We may even get more yeast infections, and also we get painful sex. Like a painful vagina, nobody wants to have. And believe me, I've gone through this. I'm married for 40 years. I like my vagina to be in good shape. And I want everybody's vagina to be in good shape. And people don't talk about this, but this is very, very important. So one, you have a dry vagina and it's painful to have sex. Two, you're not sleeping and you're exhausted. You're psychologically a bitch, and you don't want to be around anyone. And then people are wondering why it is that things are happening. If this happened to men, there would have been no decades of no treatment for them, even if it might cause an extra cancer every now and then. So basically, we have been not, as a global community, our issues have not been addressed with the importance that comes. And remember that time is a funky time relationally, because our children are leaving. You have to reestablish relationships with your partner at home. And there's a whole bunch of stuff going on there. Our bodies are changing. So there's image changes about how we feel about ourselves, about our bodies. So it's a complicated issue, but of all things, I do feel we must fix the vagina, as well as empower ourselves to be able to know the facts, so we can go to our physicians wherever they are, and then we can make the best decisions for ourselves. There's also another component to talk about here, and that's the existential one. And that is that we have to figure out, if people are going to college and having their own lives, and some of us have changed our schedules and our lives to take care of our children, how will we define ourselves now as, things are changing for us? Will we be living against somebody else's life? Or will we be creating our own life? These are very important questions in terms of what we can do, because remember, we're brilliant. We've collected a lot of wisdom in there. So we have to use it in the best way to help the world. We have bigger purposes than just reproducing and producing babies and getting them to survive in the world. We women have a big task to do, and I'm here to fight for that task and to educate you so that you can transform yourself to another level in terms of how you deal with this. So I'm going to actually now take a moment, and I'm going to open it up for the group. And I thought that we might share our own experiences as to what some of our, it appears that we have about 21 people here, so that we have some time to discuss maybe some nice laser shares about what our experience through menopause has been like. Does anyone want to start? Teresa, my sister.
So I'm very curious, because every time I do the intermittent fasting, my menstrual cycle returns. So I'm very curious about your thoughts on that. And then I have moved to about 8,300 feet, and it's very difficult for me to exercise at the same level I was doing before because of the altitude. I'm not there yet, but I have found that steady exercise just makes it easier to go through this process. And I guess I'm perimenopausal because I keep having a period. If I keep fasting, I don't exactly know where I am. So any thoughts on that would be helpful.
Yeah, so you're asking a very important question, and that is the power of fasting or the power of periods of not having food to reset ourselves to a younger stage. So I think that this is one of these interesting examples where our body reverts to a younger version of itself when we're limiting its food. This is classically how it's been done over evolutionary times to be able to protect eggs and to do things during times of scarcity so you can be ready to go when the time comes the next time. So that is number one, a classic finding, and that is the value actually of women that are in this transition or women that want to get pregnant later in life. And there's a question as to what their egg supply is and how it's going to be going, where we might recommend really dietary changes. And we'll talk about that a little bit later on. But dietary changes make a significant difference for people at multiple levels, including during the entire process of the menopausal transition. And yes, it sounds like you are perimenopausal because you're going in and out of these periods. The average age of that women have menopause is about age 51. But there, as you know, there's a bell-shaped curve along the way. So you're moving along that trajectory of that situation. So that to me makes sense very much. And then lastly, I would say regarding your question about exercise, is that exercise is the prescription that heals life. It is the prescription that can heal most things aside from sleep. Without sleep, we'll just kill ourselves or die. But I do think that exercise is transformative on multiple levels, and it's particularly important for women who are unable to have hormone replacement therapy. And I will talk about that a little bit. We have to work harder, very much. Well, in essence, as we age, we have to work harder because we're basically residue to the universe, as I discussed at the beginning. So that it is very important that we work harder to try to age biologically slower, even though we're getting chronologically older. So that's one of the ways that we do it. But so if we're not going to have hormones, we have to work a lot harder to develop that capacity that we're trying to develop to extend a life that is a healthful lifespan rather than a sick lifespan as we get older. Okay, I'll take another share. Havana, I can't see you. Hi. Let me put myself on speaker view so I can see everyone. Yes, yes.
Okay, can you hear me now?
I can hear you now. Hello.
Okay. I'm a friend of Beatriz in Miami, but I'm so excited because I found out about you because I was going around asking everyone the question that no one wants to talk about, which is menopause. I'm 61, so most of my friends have gone through menopause, but I recently had a hysterectomy, which went from 0 to 100 in a short amount of time. Make a long story short, I have had high levels of testosterone. So I was still getting a little bit of estrogen or whatever I needed. So I guess I didn't fully go through menopause. So all the changes that are occurring now to my body, I have so many questions. So I really appreciate this talk because I've been thirsty for knowledge where my friends are either have gone through it or just no one has already talked about it. So this has been very informative. I'm interested to find out who is a candidate for hormone therapy and who is not. Since my mother died from breast cancer, she always told me that I was not a candidate for hormone therapy because her cancer, I don't know, was estrogen resistant. What was the term? However, my gynecologist recently gave me hormones to take. I haven't taken them. I would like to have more of an education about, because he says that the studies that were done previously made women more frightened, and the hormones that he will be giving are the exact hormones that my body would need. So
Okay.
I'm learning about that.
Well, you bring up, Kavana, you bring two very interesting things that I will be discussing after this. This is why I opened it up. Number one, it looks like, and as we were talking about, you can have abrupt losses of your hormones if you have a total hysterectomy. So even though we think that we're not having any estrogen, there is a significant feeling in the body when we lose our ovaries. And we're not just losing the estrogen, but we're losing testosterone. Now, in Kavana's case, it sounds like there was a little bit too much testosterone. And it also sounds like, I don't know when she went through the menopause, but we also have to take into consideration the fact that her mother had an estrogen receptor positive tumor. So it's a hormonally sensitive tumor. Okay, so given this, I'm going to go now. Thank you so much, Teresa and Kavana, for sharing your thoughts, because that brings me to the next part of the discussion. And let me now share my screen again. And I want to take you to the next part, which is just a discussion that we're having right now. Is in general, people have, because of the fears of getting hormones because of breast cancer, the typical situation is that they're ignored and told to grin and bear it, that it's going to pass. They're sent to the psychiatrist to get some medications so that at least they're feeling psychologically better. But also it turns out some of these medications actually are very effective at dealing with hot flushes and some of the menopausal symptoms. Some women can get brief systemic therapy like Kavana is taking apparently, or what the doctor prescribed. And we want to talk about that. And then some people choose supplements. So I wanted to talk about the different preparations of treatments and why each one is different. Okay, so the key thing about taking hormones or not taking hormones really is an interesting story that I'd like to share with you. And that is that at the beginning, women got estrogen from years ago as the beauty or the age preserving thing for women. And then we found out that if we gave estrogen alone, the lining of the uterus would build up and women would get endometrial cancer. So because of that, we began to use progesterone, and progesterone protects the uterus from the effects of estrogen, and you could use it together if a woman had a uterus. The main problem, though, was that we were not using natural bioidentical hormones. In the United States, we were using estrogen from pregnant mares. And that is called Premarin. And we were also using a non-bioidentical progesterone. Those are called the progestins or medroxyprogesterone acetate, and they come under different names. Provera is one of them, and the other one is Ogestin. Well, it turns out that this, and of course, there's a huge amount of European literature on this, but we're America-centric. So it turns out that in 2002, a study was published nearly 2 decades ago in which they gave older women who were 65 and with some risks of heart disease oral hormones, the non-bioidentical hormones. And lo and behold, these women started to have strokes and blood clots. And there was a higher risk of breast cancer in these women. And the study was stopped. But there was an arm of women that were just receiving estrogen. And even though there was an increased risk of breast cancer in the women that were using this combination, the women that were just estrogen alone actually had a decrease in breast cancer risk. So that was very important. At that time, they were not using natural progesterone. So as a result of that study, there were 2 generations of people that were told, well, we can't use estrogen. The actual purpose of the study was to prevent heart disease, but it turned out that these women had not received estrogen or any hormone replacement for 10 years. And I told you the average age of menopause is 51. So what happened was that as a result of this event, there have been 2 generations of women that have received no hormones, including people that have premature menopause in their 30s and in their 40s who aged much faster. But the data in Europe and the new data that we have right now clearly shows that if we use bioidentical hormones, we don't have these increased risks. And the one thing that is non-negotiable is that estrogen as a pill, or any variation of estrogen as a pill, when you take it by mouth, is going to have effects on the liver that increase clotting or increase the risk of stroke. So as a result, I treat all of my women that are receiving hormone replacement therapy with patches or gels, but I don't use estrogen orally unless it's somebody who's very thin and who's a runner and he's super healthy and has a completely perfect profile and no risk of having clotting episodes. So it is true what Kavana said and what the doctor told her, that in fact we have better hormones right now, and that's natural estradiol, and we have natural progesterone. And we also can have them in FDA-approved forms, or we can have them compounded, and they work equally well. But if you're using compounded stuff, you have to know the right amount to make sure that you protect the uterus. Okay, so that's this situation. Let's continue so what I'd like to say is that I strongly believe that if you have no contraindication and you're within the beginning of your menopause to the next, or if you haven't had any hormones for 5 years, you're still within the window that you can receive hormone replacement therapy. After 10 years of no estrogen at all, then estrogen doesn't help as much and may actually have toxic effects on the brain. So it is best, and that's why I said, are you at the right place at the right time? Most women don't know that they have this window. And if you're within that window of time, you can get hormone replacement if you have no risk factors, and we're going to talk about them. So the key thing to understand is that, in fact, normal bioidentical hormones are safe. They protect you from dying early, and the benefits of it outweigh the potential risks that can come from this. And I'm going to show you all of these effects. So for example, when we lose our hormones, we become inflamed. We get a lot of oxidative stress. That is that every time we do something, there's a lot of inflammation and we need antioxidants to damp this down. And also, if we lose the hormones, we get in metabolic distress because it's a major change to where we've been. So the whole body begins to process things differently. So what I do want to tell you is that the benefits of these hormones is that they decrease overall mortality. That's how soon you die. You live longer by 30 to 40% if you're in hormone replacement therapy. You decrease the risk of heart disease by 40%. And in fact, the American Heart Association put out a statement to really rethink about the fact that a lot of women were having disease and to rethink hormone replacement therapy for them. Colon cancer decreased by 37%. Bone loss is prevented. If you remain on hormone replacement therapy, normally women lose about 10% of their bone mass in the first 4 years after menopause. And that's significant if you're starting out at a low bone mass, or if you started out lower than other people. So that's critical, because then you're at higher risk of fractures, and the big fractures are spinal and hip. So you want to try to develop that capacity, protect those bones as long as you can, if you can do it through the natural method of continuing your hormones, and recognize that hormone replacement therapy is in fact doesn't bring you to where you were, because the hormones that we give are natural, but they're much lower levels that keep you out of trouble, do protection, but don't give you so much. So I think that's important for people to understand, that we could decrease these vertebral fractures and loss of height and curvature of the back by 40% if we do this. So it's significant. Alzheimer's disease is markedly, the risk is decreased by a significant amount, 50 to 60%. And this is particularly important for people that have the ApoE4 gene, which is the Alzheimer's gene. My mother had Alzheimer's. It's actually, to me, still not clear that she had Alzheimer's, but she had many reasons for having it, which I think affected her aging in a completely different way. But because my mother had Alzheimer's, I decided to do a 23andMe test to find out if I had the ApoE4 gene, and fortunately I did not. But even if you have the other factors, but you're still inflamed, you're at a higher risk of developing Alzheimer's. But if you have the ApoE4 gene, you should take hormone replacement therapy if you have no risk, because you want to protect your brain from a natural accumulation of beta amyloid, which is what happens, and it's one of the reasons why people get Alzheimer's disease. Estrogen deficiency increases the amount of amyloid deposits that are in the brain. So that's very important. Estrogen decreases the risk of diabetes by 35%, and that's probably as a result of the fact that there's weight regulation that happens with estrogen, and that the liver metabolism is protected and the bacteria of the intestines are not affected. So that combination protects you. And we talked about the prevention of weight gain and fatty liver. And also estrogen prevents breast cancer risk by 24%. That's estrogen alone. And the combination of the naturals doesn't increase it any further. It decreases urinary infections by 60%. So in essence, were we able to keep ourselves exactly as we were before, we would be highly protected, and we would be able to extend our wellness for longer periods of time. So it's something that is important for you to understand. And I'm going to talk about some of the relative contraindications, because I think you need to know who shouldn't have. And my feeling is, after all of these years, I've been doing this for 3 decades now and taking care of thousands of women. So these are quite clear to me. If you have active breast cancer, uterine cancer, there's no way that you need to be near there. And if you've had a history of hormone responsive cancers, you definitely don't want to take it, because cancers have stem cells that conceivably hang around for a long time and then get activated. So my tendency would be not to treat with systemic hormone replacement, but I might treat these women's vaginas with low dose estrogen or testosterone. And we'll talk about that. I think it's important to know that if you've gone 10 years without hormones after the menopause, there's many other options for you to do that would help you. But adding hormones at this point would not be ideal. I do have some women that I'm giving a teeny tiny amount for particular reasons, who have benefited from that, but it has to be done very thoughtfully and not randomly, and you have to watch people. And then lastly, if somebody has had a stroke or a heart attack, not an estrogen candidate. So these are my criteria for who should avoid breast cancer. And it goes to Kavana's question. My mother had breast cancer. And what's very interesting is that Kavana is a Black woman. And it turns out that Black women are at a higher risk of aggressive breast cancers. And 1 out of 5 will develop triple negative cancers, which are the more aggressive. So I would take into consideration Kavana's age and her situation. I might use the lowest hormones, or I might do something in a combination of things to try to protect her as much as possible, given the fact that we have this risk in her family. Although I must say that breast cancer after age 50 is actually a more benign disease. No one wants cancer, but it turns out that our risk of having cancer is about 13% in a lifetime. 1 of 8 of us will have breast cancer at some point or another. And so there's a natural tendency for us to develop cancers as we get older. And as we get older, we have less and less capacity to protect us against those cancers. This is why it is so important to maintain a holistic approach with our diets and how we take care of ourselves. Okay, Kavana, you have a question?
Yes, my question, I noticed that you said between 60 and 65 that you would not take the HRT. Now, the Diagel,
Divigel.
okay, was what was suggested to me, but based on what you're saying, I would not be a candidate for that.
Well, I think I would have to talk to you in a different way, but I think that if you've been a long ovulator, some women have periods until the age of 58 or 59, okay?
I was 51, but my
Okay.
testosterone was like 200 and something.
Right. So for you, Kavana, given the 10 years that you've had between 51 and now the age that you are, I would consider other options. I would protect your uterus, and I would consider other options to protect you, okay?
Okay. No, you full hysterectomy last year.
Okay, well then that's very good. So then we don't have to worry about your uterus anymore. Okay, so let's move to other options that let's move to other issues that are very important for you to know. How are we doing, everyone? Am I being clear? Is everybody getting a sense? Can you give me a wave that we're in a good place? Okay, good. I don't want to disappoint. Okay. So I want to talk to you a little bit about the fact that we do have non-hormonal treatments that are very effective for women who cannot take hormones, for women that do not want to take hormones, because this is really a very personalized decision. And lastly, if we're in this category of women that probably should not take hormones, we have to target the symptoms. Because what I do want you to know is that while estrogen takes care of all of the global menopausal symptoms, the other options target different things, but none of them are going to address the whole package, okay? So we have to do a lot more of combination to be able to help a woman in that situation. So I want to talk to you about the types of hormonal treatments that we have for women, because you need to know if you choose to use it, you should know kind of the ballpark of what we're doing using hormones, and then let me see the sexual symptoms. Okay, this is the one. Okay, so if we're going to use hormones, I like natural progesterone, nothing but natural. We don't allow anything else but natural stuff in our bodies. Okay, so we use natural progesterone and estrogen. I like progesterone as a pill if you're having trouble sleeping. I like it in the vagina otherwise, but most people want it for sleeping, so I use natural progesterone. They work just the same. The same pill can be put in both places. I use estrogen and of course in small doses that make a difference and help the bones and other things. And the estrogens I use as patches, gels, or creams. And testosterone I use for decreased libido, which we experience in the menopause, and vaginal testosterone and vaginal estrogen and vaginal DHEA all help the vagina stay healthy. Estrogen being the best, testosterone being outstanding, and DHEA being available, and that can be compounded as a suppository in a compounding pharmacy. Any of this stuff can be compounded or can be used through FDA approved mechanisms. And I wanted to talk about the non-hormone treatments. I think it's down here. Yeah. So, okay, so these are treatments other than hormone replacement therapy, and they're targeting different areas. For the hot flushes, if you're, and I explained to you how these hot flushes are happening, we have a lot of options for what to do with the hot flushes. So it turns out Japanese women don't have so many hot flushes. But it turns out that when they enter a westernized diet, they begin to get hot flushes. So there have been studies that show that diet really does make a significant difference. Remember that certain foods in our diet are really not so healthy. They're processed, and some of the meats we eat are inflammatory because the animals have not been treated right. So they come as inflammation in our body, and then that exacerbates our own inflammation and makes the symptoms worse. I also want to tell you about the placebo effect, which is very interesting. To find anything that helps with hot flushes, you have to overcome a 35% improvement that happens naturally if you tell someone that you're going to give them a treatment to decrease their hot flushes. So there is a sense at some level, even though we truly have a biology for the hot flushes and the night sweats, that there is a consciousness component to our experience and the distress that we have by these things. So diet is very good. Our meditation, mindfulness, Qigong, anything that we can do to truly balance ourselves and connect to our whole, align ourselves, life is going to be experienced significantly different. If we're stressed and we're not dealing with our stress, our flight fight system is going to be activated, and everything is going to be much worse. And then we can also use antidepressants like Paxil or Effexor, which are available, and they do decrease hot flushes and night sweats, only that, of course, everything has a problem to it. You know, if you take the antidepressants for a long time, it can affect your bone mass. So what we're doing is we're doing different levels of things that we try to address. For the vagina, for women that, in general, I can use estrogen, vaginal estrogen on everyone, even women with breast cancer, teeny tiny amounts, because the estrogen stays in the vagina. But I can use testosterone, and testosterone is very protective to the breast, and I can also put it in the vagina. And for women that want no hormones level at all, you can use hyaluronic acid, which is very nice and keeps, you know, just like you put hyaluronic acid in your face to plump it up, you can put it inside of your vagina to plump it up, and it works just as well. So there's many ways that we can deal with the vagina. However, and also there's drugs too that we can use to increase libido, but I'm going to tell you something. Women are different than men. Our sexuality and our interest and our arousal is 90% in our heads, whereas for men it's 90% in their penis. So that the key thing is that I can throw a whole bunch of things at you. And if you're not in good relationship with your partner, it's unlikely that you're going to have the experience that you're looking for. And I do feel strongly that this is a time of our lives to really evaluate our relationships. And a lot of us also have body issues because we're gaining weight. We don't feel good in the bed. We don't feel that good that we're going to be looked at. And we got to stop all of this business. You know, it's like the whole idea is if your head is 2 area codes or zip codes away from where your body is, you're missing the experience. One of the important things that can empower us as women as we mature is to be present in your body. This is the time where we should begin to really appreciate the fact that we have this body and this time to live in, this period of time, regardless of how this body is. We can always improve it, but we can love it. And it's only through self-love that we can actually truly love somebody else and truly accept what they give us without pushing it away because we're being so self-critical of ourselves. Being self-critical is a jail. And it's very important to let it go at this time of life. If you're going to let it go, this is the time to begin to do it. And usually when we're critical, it comes from our childhood. We're critical because we did not want to be criticized. And a little part of us became very protective of our criticism. So we're very protective of how we show up. So we're not criticized. But that's an old, younger part of us. This is not who we are right now, the wise women that we are, the women that get awareness from each other, that learn from each other. We have a different possibility to truly experience our bodies and our minds and really connect with our consciousness and spirit at a higher level. We can have the best experiences if we feel safety and trust with our partners. But that is absolutely necessary to have true sexual intimacy, and of course, have other types of intimacy too. Okay, so I am going to do a stop for a second, and I just wanted to hear from the gallery, how are people being treated for their situation? I'd like to hear who's getting what and when. Sarah. Hello, Sarah.
Hi. Well, I am cheating because Dr. Olson is my doctor and she's phenomenal. And I cry every time I'm in there and she saved my life. And I mean that. So I've learned a lot and I've come a very long way in my journey. And I realized this is not the best time for this question because you are asking me how I'm being treated, which is progesterone. Right now I'm in perimenopause, but I have a history of a lot of different things. But my question, and if you might touch on this maybe later or my next appointment, is the connection with methylation.
Oh, such a good question.
That just was crept up for me and just something that I'm working on now. So thank you for this talk. Thank you for going above and beyond always. And yeah, I'll leave it at that.
So I'll leave it as that. It's a mutual love fest between you and I. But I think you asked a crucial question that I want to talk about. Actually, thank you for doing that. I'm going to share the screen right now because I think it's very important what you just asked. I think that hormonal treatments, whatever, actually, I think I put it back here to the woman who uses the BRCA genes. Okay, it's a very good example. So I have women that have the BRCA1 and 2 gene, and the treatments for them are usually a risk reduction salpingo-oophorectomy. That means that we remove the tubes and the ovaries in their 30s, so they become acutely menopausal. But we want to give them hormones. And the other thing that's very interesting, which you may not know, but these women who are at high risk of developing ovarian and breast cancer really benefit from birth control pills. Now, you might say, why would that be if you're giving hormones to women that probably shouldn't have hormones? Well, it turns out that birth control pills turn off the ovary. So actually, birth control pills actually decrease the risk of ovarian cancer. Okay? Because the ovary is not popping out follicles all the time and ovulating all the time. And remember that every time that there's an ovulation, it's an inflammatory event. You're having a big reaction that is happening in the ovary, and it's within the space of ovulation, oxidative stress, that actually leads to changes that lead to cancer. But the question is, how do you ensure the good metabolism of estrogen? So estrogen is metabolized 3 ways. Okay, so estrogen is metabolized through a nice, good pathway that's called the 2-hydroxy pathway. It's metabolized very nicely. So what happens is that the estrogen is changed, and then it is processed further by attachments of little methylations, little clumps of things get added along the way in the liver, so that the estrogens are processed nicely. They're poured into the bile, and then they go into the stool and we poop it out. Then there is a more aggressive way of how estrogen metabolized, which turns out to be common in women that don't have a genetic risk for breast cancer, but through we use a Dutch test, is what we call, to identify how women metabolize their estrogens. So, and these women tend to metabolize their estrogens through the 4-hydroxy pathway, which is more carcinogenic in terms of the processing. So we can use supplements to shift the profile of these women. And if they're poor methylators, or if there's a reason that they don't have enough B vitamins, that they don't have the right stuff to help the liver put little packages around this estrogen so it gets pooped out. If we don't have those things, then the estrogen can hang out for longer. Okay, so yes, it's very important. There is a pathway to metabolize your hormones, and even if you take hormones, there is a good way of metabolize them using them. Actually, the best foods, I'll tell you, the Brasilica family: cabbage, cauliflower, broccoli, and Brussels sprouts. So if you eat a lot of that, that has what is necessary, the diindole methane that is necessary to shift your estrogens to go into the healthy pathway, rather than going through a different pathway. And then there's other more complicated things that we can do. Of course, the B vitamins will help very much. Methylated B vitamins are very important because some people have blocks of how they process their B vitamins. And then we can use other protective mechanisms depending on what we're doing. But we're very mindful. And I also want to comment that if women are taking estrogen and they have a uterus, sometimes, despite the fact that you use estrogen and progesterone, you might still have an increase in the lining of the inner lining of the uterus. And my measurement mark is 5 millimeters. So I do ultrasounds, vaginal ultrasounds in people to just make sure that the uteruses are behaving well and responding well to the little hormones that they're receiving. And if the inner lining gets bigger than 5 millimeters, that can cause irregular postmenopausal bleeding. And of course, you want to rule out the possibility that you're developing a precancerous or a cancerous situation. So thank you for asking that. The metabolism is very important. And fiber is huge, guys. Fiber and vegetables is huge, because fibers really help you get rid of all of the toxic stuff in your body. So you're moving your bowels every day. You're not holding toxicities. And the other thing is that non-digestible fibers are fabulous for your bacteria in the colon, which makes the small chain fatty acids like butyrate. And those compounds are very important for keeping the lining of the intestines healthy, so you don't get any leaky gut. And also they're very good for connecting with the liver. So the liver knows that it's getting the right information in the gut-liver connection. So when all of these things are happening, you don't gain weight and you don't get the inflammation of a leaky gut, and you're getting rid of your hormones. So there are very smart ways of doing this with bioidentical hormones, ways of cleaning your system, and ways of cleaning yourself and taking care of yourself to decrease the stress. And of course, I always say this, but I just want to make sure that you have to take care of the basics, okay? Everybody has to sleep. We are all dealing with, our bodies are like monkeys, and we're dealing with a modern world. Our bodies are evolutionarily made over thousands of years, and everything has changed in the last 150 years, yet our bodies are not prepared. So we're supposed to be sleeping when it's dark and be awake during the day. Our hormones work on that cycle in the circadian rhythm. So we need to sleep, and we need to sleep 7 hours to be okay. We need to move our bodies all the time. I think this is very, very, very important. We need to have connection with others and things that make us feel good to counteract the natural stress that is happening in our lives. And we need to have ways of decreasing stress, because stress is inflammatory. Stress is inflammatory just like losing estrogen is inflammatory. So you have to do the basics, the right diet, the right exercise, the right sleep, and the right tending of yourself and nurturing of yourself. And often we women don't take care of ourselves. We don't include ourselves in our circle of care. We're taking care of everybody else but ourselves. And I'm telling you, it's most important at this time of our lives that we take ourselves as our serious project. We are the project. And it's through us that we can actually, then you have to help the body. Because if you don't help the body, you can't express your brilliance. If you lose your vision, if you lose your mind, if you lose your movement, because the body wasn't right, you're going to have to be taken care of by another. And you're not going to be able to give your fullness to the world. So these are all very important components of how to take care of ourselves. And especially coming from me as an integrative endocrinologist, I just want to be sure that everybody understands that. But the point I'm trying to make here with the situation is that even women that are at high risk of breast cancer are getting hormone replacement. And in fact, this was an article that was just published this week in Menopause, in the Journal of Menopause, doing a meta-analysis of women that have these gene mutations and then get hormone replacement therapy. And they do quite well, actually. They do quite well. So I think that is reasonable to give people the opportunity to try with or without. And there's many ways of fixing things to our advantage. There's many ways of doing that. Although, as I said, you have to use different parameters to help people that are not using hormones, because there's many things that need to get fixed. Let me see what else I have forgot before I open it up for the group. Okay, we talked about the vagina. We talked about the hot flushes, the many ways of dealing with them. We talked about the genes, and we talked a little bit about the weight, as to how to deal with the diet, and of course, how to deal with the gut-liver connection. And Tere, my sister, brought out the intermittent fasting, which I think is very important. So at the end of the day, it's about really creating a holistic approach to yourself, create a plan, and try to figure out how it is that you can tend to all of these different levels of being, so that you can have the highest potential to offer others and to help the world with your unique brilliance. Okay, so I'm going to stop here right now, and I'm going to open it up for the group to give me feedback as to what you found interesting and or useful to you, or if you have something that I didn't discuss but you think it's helped you and you would be so kind to share with everybody, that would be wonderful. Hi, Kim, I see you there. Hello, Kim.
Hi, Dr. Beatriz. Sorry, I had to unmute. How are you? First of all, I want to thank you so much for giving up your free time tonight and doing this for all of us. This is really so interesting and so appropriate for all of us at this stage in our lives. And it's really helpful. You're always such a world of knowledge. So just to tell everyone, I've been a patient of Dr. Beatriz's for a very long time. I had a miserable experience with menopause, but you've really rescued me and saved me. And one of the things, I mean, I always have questions, you and I always get up on these discussions, but one of the things that's been coming up lately, I'm 63. We obviously, as we get older, we have to see other doctors besides you, and we have to go to, internists, gynecologists. I've had bad luck. All my gynecologists over the last several years have either retired, left the field, whatever, just different experiences. But I always find like I get browbeaten by them to not be on the bioidentical. I've been on bioidenticals, as you know, I should tell everybody else, for a long time. And everybody's always, all the traditional or allopathic doctors always say, get off the bioidenticals. There's a black box warning about testosterone, and they all try to cite their studies and tell me literature. And it's most of the time I just end up changing doctors because I just don't believe in that philosophy. I'm educated myself as well, besides talking to you, and I just don't agree with it. But one question I've never asked you, and I actually would like to know, is that do you feel I know there's a lot of studies promoting how safe it is. Do you feel it's safe to stay on it the rest of your life? You know, if I've been on it since my early 60s, can you do this in your 80s or 90s? God willing, I'm still alive.
Yeah, well, it's very interesting question that you ask. I have patients that have been on hormone replacement who are now in their 70s, who are using small amounts of hormones and are doing very well. There are some studies using the non-bioidenticals that as the years go by, after 10 years of being on hormone replacement, there's a higher risk of breast cancer, but we all have a higher risk of having breast cancer as we get older because we don't have the protective mechanisms. So it depends on how healthy you are. It depends what the risks are. And also just being aware that the fact that women that are on hormone replacement therapy and develop breast cancers, which some of us will, have a very much benign course relative to women that have not been monitored and not been on hormone replacement therapy. So I take that as a case at a time. I mean, nobody has really looked at women like us that have been doing these things and studied us for 25 years. We've just become a commodity to begin to study. As it was, all studies had nothing to do with us women, and they've been geared to scare us. I do want to tell you, testosterone is highly protective to the breast.
Yeah, I mean, I've always heard that and read that, but it's mind-boggling to me what other doctors promote. And honestly, most doctors are they don't continue their education like you do. You not only read a lot and investigate a lot, you go to clinics and you continue your own education in so many ways. And other doctors, they just don't, and they don't know anything about nutrition. So it's very disturbing.
Well, I thank you, Kim, and I just want to say that I would like you all to take a screenshot of 1 or 2 slides that I have here, because I would like you to show your doctors.
Yeah.
I think it's
did
important
take
that you be armed with information. And in fact, you should go to my website, which is the beatrizolson.com. And if you go to the blogs and you look at HRT, you actually have the references for each one of these statements that I've made into a little graph for you. You have to go armed. People are going to be studying. I happen to be a nerd about some particular topics, but this means a lot to me. I'm here to stand for us.
Yeah.
I'm here to serve as a healer for women.
And
I feel very strongly about it, but I do want you, I'm going to put this, and I want you to take some screenshots, because you guys got to help yourselves. And that's why I'm doing this. If you have awareness and you have the skills, you can talk to people. And the scary thing is that a lot of people are giving hormones that are not trained to give hormones, but they will be making money. So you have to figure out yourself how much or what the situation is going to be of how you're going to go about this. Okay. So I'm just going to go back to a key one, and then I'll take another question from somebody else. But just take, I'm going to go to this one. Okay. So I want you to take a screenshot of this one. Let me see if I can make it a little bit bigger.
If you could move it over to the the left of the vertical bar of all the guests in the Zoom.
Okay.
It gets covered up by all the.
How about now? Is that good?
I think you have to go the other direction, actually.
Oh, okay.
Because the right side of that screen is covered by everyone's faces. Yeah, that's
okay.
That's
is that better?
Yeah. No, that's great. Yeah, that's great.
Okay, take a screenshot of that, because I think it's a very important thing. And these are the data. I mean, it's non-negotiable. You look at the American Heart Association statement about heart disease in women last year in 2022. Look at the statement in menopause about the treatment of women with testosterone with low sexual dysfunction and disorder. None of these things affect our hearts in any way. The only bad thing is when you put testosterone in the mouth or when you put estrogen in the mouth, but otherwise you're pretty protected. So I'm empowering you. That's the whole point of doing this. So that
Believe
you
me.
can go and discuss with people this. And I thank you for asking this, Kim, because I think it's important that you guys go and you have a discussion, but do go to my website and then you'll find the individual references, print it out and bring it to your doctor. Okay.
Thank you. And I'll be seeing you soon for my annual. Thank you very much.
I look forward to that, Kim. I look forward. Okay.
Likewise,
So now
Thank you.
let me get out of this for a second and then let me get the last few. We're almost at the end, or we are at the end. I don't want to take any more of your time. Hello. I'm seeing a lot of people that I'm so happy to see. Okay, so we're at the end. Any burning question before I give you your blessings? Oh, Kim. Hi, Kim.
Another Kim.
There's my book editor, my beautiful book editor over there. Hi.
Hi there. In fact, that's why I'm on. I just want to let everyone know both Janice and I are helping Beatrice with her book. And I tell you, you're going to want to let every woman and men who love women know about this awesome book. What an honor to be a part of this project, to gain this wisdom. Beatrice, you're amazing. I'm so glad there's a recording of this. I'm like, oh, there's more. There's going to be another book after this one because you're just filled with so much knowledge that really helps all of us. Really grateful for you, and I'm glad to be here today.
With so much love, Kim, and gratitude. Thank you. Well, if you guys feel complete, first of all, I want to congratulate you for taking the time tonight to learn more and to take care of yourselves better. And let's close with my blessing. I like metas. Metas are prayers in the Buddhist tradition. May you be safe. May you have discernment. May you make the right choices. May your body be enlivened and vigorous so that you can give to others what you're here to give. It's an absolute pleasure, everyone, to see you this evening. And I look forward to our next time. And I will do probably 2 or 3 more of these over the year. And then I'm counting on you guys to pass on my book to other people when the book is out, okay? All right, well, kisses and hugs to everyone. Have a good night and goodbye.
Night.
Goodbye. You can unmute yourselves and say goodbye.
But
Bye.
Bye-bye.
Bye.
Bye.
Thank you.
Bye-bye.
Bye, Michelle.
What a delight. Good night.
Good night.